Welcome to This Explainer. Okay, let's just dive right in. Today, we're decoding the complex landscape of psychobiologic disorders and the specific clinical medications we use to treat them. We're going to look closely at the exact tools healthcare professionals use to actually understand and manage mental illness.
So that brings up a really fascinating opening question, right? How do we treat illnesses that we literally cannot see? In medicine, we can easily set a broken bone or surgically remove an appendix, but treating the mind, that requires an entirely different approach. It relies on a super careful blend of modern pharmacology and highly structured clinical tools to bring patients back to stability. Here's our roadmap for today. We'll be hitting 5 key areas. First, assessing mental health. Second, anxiety and trauma disorders. Third, schizophrenia and psychosis treatments. Fourth, managing major mood disorders. And finally, cognitive and personality disorders. All right, Section 1, assessing mental health. Let's look at how we map unseen symptoms. So, the mental status examination is exactly how we do this. It breaks down into 4 clear, actionable steps. We observe a patient's appearance in activity, evaluate their mood and affect, listen to their speech and language, and analyze their thought content and process. This is how clinicians systematically take highly subjective feelings and turn them into objective, actionable clinical data. And it's really important to realize that this is not just some simple one-time checklist. It's a comprehensive tool used continuously throughout a patient's entire treatment journey. We're looking deep into domains like sensorium, which is basically a patient's orientation to time, place, and person. We're checking their memory recall, and we're gauging their insight into their own condition. It's really the absolute foundation of psychiatric care. Moving on to Section 2, anxiety and trauma disorders. This has all got managing intense fear. Let's start with generalized anxiety disorder, or GAD. I want you to imagine the completely exhausting reality of cyclical, unmanageable worry that happens more days than not for at least 6 straight months. And it isn't just in the mind, It actively wrecks daily functioning and brings on severe physical symptoms. We're talking restlessness, crippling fatigue, muscle tension. So how do we actually intervene medically here? Well, our primary pharmacological tools for anxiety fall into 2 main camps. First up, SSRIs, or selective serotonin reuptake inhibitors. These are your first-line long-term management meds. They're incredibly effective, but they require a lot of patience as they take time to actually build up in the system. On the flip side, we have benzodiazepines. These offer immediate, rapid relief for acute anxiety. But, and this is a big but, they come with a very dangerous risk of physical dependence and severe withdrawal. Because of those risks, the absolute top priority when prescribing these anti-anxiety meds is patient teaching and monitoring. For example, abruptly stopping a benzodiazepine isn't just mildly uncomfortable for the patient, it can lead to severe, life-threatening withdrawal symptoms, literally including seizures. Patients absolutely must be carefully and medically tapered off. Of course, medication isn't our only tool. When managing an acute crisis, like a sudden panic attack or an acute PTSD flashback, clinical staff have to prioritize immediate physical and environmental calm. The protocol? Remain completely calm, use very short, simple instructions, move the patient to a less stimulating area, and guide them through deep breathing. You literally have to de-escalate the physical environment before the mind can even begin to follow. Okay, Section 3. Schizophrenia and psychosis treatments. We're looking at how to treat a distorted reality. First off, we need to clearly define psychosis. It's a state where a person has profoundly distorted perceptions of reality. They're frequently experiencing delusions, so false beliefs, hallucinations, and highly disorganized speech. Grasping this is key because it highlights the massive gap between the patient's terrifying internal experience and external reality. To them, the hallucinations aren't a symptom. They are entirely 100% real. To treat this, we rely on antipsychotic medications, which, to be honest, have seen a massive evolution over the years. First-generation typical antipsychotics target what we call positive symptoms. Think of these as things added to reality, like hallucinations and delusions. But they carry a really high risk of extrapyramidal side effects. Those are severe movement disorders. Second-generation atypical agents, they represent a huge leap forward. They treat both positive symptoms and negative symptoms, like a flattened emotional affect, with a much lower risk of those movement issues. However, they do introduce new risks, specifically weight gain and metabolic syndrome. And these are incredibly powerful drugs that come with a pretty daunting list of potential side effects. We're talking everything from severe postural hypotension to serious blood count drops with medications like clozapine. The sheer volume of potential adverse reactions here reinforces exactly why constant clinical vigilance and routine lab monitoring are strictly required when administering neuroleptics. An absolutely crucial point regarding patient safety is tied directly to side effects like tardive dyskinesia. This is a usually irreversible syndrome featuring persistent involuntary movements of the face, jaw, and tongue caused by prolonged antipsychotic use. It vividly demonstrates exactly why psychiatric medications have to be so carefully balanced. Treating the mind without harming the body is essentially a constant clinical tightrope walk.
Right. Moving on to Section 4, managing major mood disorders. Let's talk about extreme emotional states.
When we look at antidepressants, SSRIs are generally our safe first-line go-to. Tricyclics are much older, and while they're effective, they carry a really high risk of lethal cardiac dysrhythmias if a patient overdoses. But here is a super surprising and critical medical fact. If a patient is prescribed an MAOI, they require a very strict tyramine-free diet. That means absolutely no aged cheeses, no cured meats, and no draft beer. Consuming these everyday items while on this medication can actually trigger a sudden, life-threatening hypertensive crisis. Now, there is a fascinating yet honestly tragic clinical paradox we have to be aware of regarding antidepressants. When a severely depressed patient starts taking them, their physical energy levels often increase before their mood fully lifts. And because of this sudden newfound physical energy, the clinical risk of them actually having the capability to carry out a suicide plan paradoxically rises during those first few weeks of treatment. It's something we have to monitor very, very closely.
Pivoting over to bipolar disorder, the gold standard treatment for decades has been lithium. But lithium has an incredibly narrow therapeutic range. If blood levels get even slightly too high, you're going to see toxicity signs like severe nausea, tremors, and confusion. So here's the massive takeaway. Lithium is excreted by the kidneys, so maintaining adequate hydration is literally a matter of life and death. Even just a heavy workout on a hot summer day without enough water can accidentally push a patient right into lithium toxicity. Beyond other effective mood stabilizers like Depakote and Lamictal, nursing care during an acute manic episode is absolutely critical. Interventions here have to focus on drastically decreasing environmental stimuli. Practically speaking, nurses often have to provide high-calorie finger foods because the manic patient is simply way too hyperactive to sit down at a table for a traditional meal. Finally, Section 5, cognitive and personality disorders. We're focusing on pervasive deficits. It is absolutely vital to distinguish between two frequently confused conditions here. Delirium has a rapid onset. It's often tied directly to a specific underlying medical issue like a bad infection or a medication interaction, and, this is key, it's a reversible medical emergency. Dementia, however, has a slow, insidious onset. It is a progressive and tragically, typically irreversible cognitive decline. Identifying the difference between the two immediately dictates our medical response. When we look at personality disorders, borderline personality disorder really stands out for its clinical intensity. These patients experience highly unstable relationships, severe mood swings, and they utilize a defense mechanism called splitting, where they basically view people as entirely good or entirely bad, with absolutely zero middle ground. And because of the recurrent suicidal or self-mutilating behaviors associated with it, the highest clinical priority for nurses is establishing strict, consistent boundaries to prevent self-harm. We've covered some truly incredible ground in this explainer today, from the highly structured data of the mental status exam to the very delicate biochemical balancing acts of neuroleptics and mood stabilizers. And it leaves us with a pretty provocative final question. With psychiatric medications evolving so rapidly, how exactly will our expanding understanding of the brain transform mental health care tomorrow? The human mind is undoubtedly complex, and the medical quest to heal it is definitely one of the most fascinating journeys we can study. Thanks so much for joining me today.